last talk of the afternoon, which will be given by Suchitra Chandrasekaran, who is an assistant professor in the Department of Gynecology and Obstetrics here at Emory. And she previously served as an affiliate assistant professor at University of Washington Division of Maternal Fetal Medicine. She received her Master of Science degree in clinical epidemiology from the University of Pennsylvania in 2012, and earned her medical degree from Northwestern University Feinberg School of Medicine. In 2002, she completed her residency in obstetrics and gynecology at the Ohio State University, go Bucks, and a fellowship in maternal fetal medicine at the Hospital of the University of Pennsylvania in 2013, and was a T32 NIH grant trainee in clinical epidemiology at UPenn in 2014. So let us welcome Dr. Chandrasekaran to give her lecture on the Emory Postpartum Metabolic Clinic.
Okay, so it's the green button, right? That's what we do. Got this. It's the last talk of the day. My talk is really light. I want to keep it open. Stop me, ask questions. This doesn't have to be me speaking to you. This is just an initiative we've started at Emory, and so I wanted to share it with this group. And so I'm open to like feedback, questions, ideas. That's kind of the purpose of this one at the end. I'm going to talk about two things we're doing at Emory. One is this Emory Postpartum Cardiometabolic Clinic. And then another thing we've started with GaPQC, with Lisa, Missy, the whole Our Cardiac Bundle crew, to do a postpartum patient education series. So I'm not going to give too much data because we've gotten a ton of data today. But I think the reason I kept this slide in here, something didn't translate there, but it's okay. I can still do it. There's a bigger problem postpartum than that immediate postpartum. So there's the immediate postpartum, right? Kind of like what Dr. Hirschberg talked about at Penn. And yes, that 2012 data was me in the clinic, that postpartum clinic that she presented when I was a fellow. So that started there. And so there's that immediate data, but then there's a problem. Long-term, your risk for cardiovascular disease, and specifically arteriosclerotic cardiovascular disease, so stroke, heart attack, and coronary artery disease, is twofold higher if you've had preeclampsia, almost 1.5-fold higher if you've had gestational diabetes, and 1.5-fold to twofold higher if you've had cardiovascular disease. So this is long-term mom's health, maternal health. Diabetes. So it's interesting because we know if you have gestational diabetes, we see a 4-fold increased risk for type 2 diabetes, and some studies even goes up to 7-fold. But interestingly, preeclampsia also increases your risk for long-term diabetes because the concept is it's a cardiometabolic dysfunction that is occurring. And then, of course, metabolic syndrome, right? And let's be clear, all of this is completely confounded. There's other lifestyle factors going on, but ultimately what we need to remember is that it's not just what's happening during the pregnancy, but that during the pregnancy has significant long-term effects. But not only does it have significant long-term effects, they're entering their next pregnancy with those long-term effects because likely they didn't get that long-term care that we need. So this is where this kind of idea started to grow. Of course, ACOG. ACOG is great, right? Because ACOG has to give recommendations. So they gave this lovely table, table 1, because we all love our tables. And they gave us only a few things to do postpartum. And any of us who've done OBR postpartum returns, we know how that goes. I was at the University of Washington where MFM ran labor and delivery and did our own OB. And so, yes, my postpartum visit was 20 minutes, nice little slot. They were booked back to back. And let me tell you, I didn't finish all that in 20 minutes. Didn't even come remotely close to finishing all that in 20 minutes. And now we've said for pregnancy complications and specific association with ASCVD, we're supposed to do all of this screening, and then let's add mental health to that piece of it. Okay. And then, of course, let's not forget the chronic health conditions that need to go on here. So this is what we need to do. Forget that whole table, just specifically regarding chronic health with exposure to a gestational metabolic disease, you should consider all of these things. And again, as clinicians, as providers, we know how easy this is to do in a postpartum visit when you're already dealing with potentially a C-section scar, whatever else may you have it. We're now supposed to consider AHA screening questionnaires, statin use, lipid monitoring. Do you have primary care? I mean, this is a lot. And so this got me to thinking, maybe there's a different approach to this process. And this is something I had started at the University of Washington, where I was for 7 years before I ended up in Atlanta. And so I thought, we should start a postpartum cardiometabolic clinic, but not doing it as I had witnessed at Penn at that 10-day mark when you have a new baby and you're still overcoming what that means. As a mother of 2, I know what that means. At 10 days, you are not quite ready for anything. Fair. And so I was like, maybe let's try it at 12 weeks postpartum, when they've had a minute to get over things, when they've had a minute to think about things, and let's see how much they understand what's going on. And really, maybe we can prevent some of those long-term maternal risks, but really it's kind of re-entry into another pregnancy. So I went to Missy with this idea, and she's fabulous. And she was like, well, why is it an idea? You should do it. And I was like, I guess I could do it. I don't know, maybe. So then I went to my people, Dr. Jameson, Dr. Castellano, amazing folks at Emory, and they're like, sure, you want to try it? I was like, sure, I'll try it. Why not? Let's do it. So that's literally what we did. So at this current moment, anybody who has delivered at Midtown, Decatur, Grady's allowed to refer in as well, who's had any hypertensive disease or diabetes of any kind or any other cardiometabolic issue. The only thing we don't do is congenital heart disease, because obviously that's kind of a different pathway. Iris Krishna's got that covered, it's fine. So we don't do that, but we do all the other cardiometabolic disease. They can be referred to us. And by us, I mean me, because right now it's a one-man show. I schedule them out at 12 weeks postpartum. It does not replace the standard postpartum visit. That still happens at 6 weeks. This does not come under the bundle. So then comes billing, because we can't avoid the billing question, but we have Georgia Medicaid right now for a year, and that is helping us. And we are finding that we charge it as it's a preconception consultation of sorts. And so it does get covered. This has not been an issue so far. I offer both in-person and telehealth visits to do this clinic. It started in September of 2022. I do 1/2 session per week right now. So I see 6 patients at 30-minute slots. For the most part, most of my slots go above 30 minutes. But sometimes with no shows and things, it evens out. So I'm keeping the schedule as is for now, because remember, we've just started up. Again, anybody with this history can be referred. And then I refer out to cardiology, endocrinology. I have mental health resources. I've created a pamphlet. I refer to psychiatry if needed. We also actually have now created a collaboration with our non-surgical weight loss center, the Emory Bariatric Center. And so we have pamphlets, we hand it out to them. So we've really kind of been able to build a nice little collaboration of referrals and providers. My long-term goal is a multidisciplinary clinic that actually runs with cardiology, endocrinology, and psych and nutrition, potentially like a couple of days per week, and like 1 day a week cards come, 1 day a week endocrine comes, that kind of thing. I have already planted that seed into Dr. Castellano and all the folks at Emory's head, because I think this would be great. There's some thought to think about this. Dedicated providers, 2 to 3 OB providers, do telehealth and in-person options. We've talked so much about healthcare deserts here in Georgia. I mean, if people could get to a local Department of Public Health, get a blood pressure, get this, and then I can say what we need and do these visits, this could be huge. And really, this is my long-term regional goal, to take it one step up. So maybe this is like the 10-year goal, maybe earlier, I don't know. And so the idea is you could really deliver it any obstetric care, local, regional hospital, and then you would be referred to our clinic. We're thinking of calling it Blossom After Baby. It's a center for postpartum women's health. The idea is you could do telemed, and we could like coordinate with the DOH and get in-person or referrals and connect with other specialties. None of this is possible without collaborators. So I have a lot of collaborators through Emory, but my goal is to try to build that through the state of Georgia. So whether that's family practice, whether that's mid-level providers, whoever it may be, people we can communicate and talk to so that they know they need their blood pressures done, they need their lipids done, kind of that whole gamut. So that's my long-term regional goal for the clinic. Again, we've just started, so we're in the early phases right now. I would say in the many years I've been doing this, this has been the most humbling clinic I've ever done. Because the truth is, I've never talked to a patient 12 weeks postpartum, neither in my training, nor in fellowship, nor even as an attending who was doing my own OB practice and clinic at UW. We saw them at their 6 weeks and we said bye. And I think we just talked about this earlier too, how everything seems to end after baby, you know? And so this is the first time in my entire training and life, I'm talking to people at 12 weeks and truly talking to them, taking a minute, sitting down and having this heart to heart. And you know, it's fascinating. Patients often do not understand why they were delivered. Exact words. I've had a patient with blood pressures in the 200s over 100s. And she said, but I had one reading in the 150s over 90s. I don't know why I got delivered. This has nothing to do with the doctors. I had to go back and look at the record. They're some of our best. They're amazing. I'd let them all take care of me. They're fabulous. I'm sure she was communicated to. It didn't absorb in her head. There's a difference. It's not that they didn't say it. It didn't get in her head. Explanation of health risks at the time of delivery is overwhelming. I don't know. Dr. Suchi, that time was so overwhelming. I could only absorb so much. I couldn't take it all in. You know, the resident came in, the physician came in, they told me something. I was scared about my health. I heard the word stroke. The number of times I heard the word stroke. I think their brains just stopped there. I heard the word stroke and seizure and I'm done. You know, we say it. I'm sure I've said it. I'm sure I could have been the doctor there saying it and they would have said the same thing. I heard the word stroke. They always thank me at the end, which is funny because I want to thank them because they've taught me so much, but they always thank me. They say they appreciated the opportunity to debrief and talk about what happened and often feel better about it and often don't feel guilty about it because they're like, oh, I was able to understand maybe why I was delivered or what happened or why it was preterm because it didn't go in their head at the time. And sadly, they are not aware of their long-term metabolic health risks. They're like, well, I was told I had some high blood pressure in pregnancy. I'm fine now. And I went on my merry way. I'm pretty certain that's not what we say, to be honest. I actually have more faith in our system. I have faith in our physicians. I have faith in our providers. I really don't think we say that. I think we don't have time to message better because this requires its own discussion to be able to explain it to them. And then 50% don't have primary care physicians. And that's not a huge surprise because a lot of this is young reproductive age women. I didn't have a primary care physician, can't blame them, you know, but still, like many don't have primary care physicians. And these are just some of the quotes I hear. I want to do something together to get better, but I don't know what to do. I didn't feel heard. Oh my God, the number of times I hear I didn't feel heard. I didn't feel my story was being heard. Some postpartum stories are quite fascinating. This is actually a common theme. I told them my blood pressure was elevated at home, but the ED, I was told it was fine. So you get these patients who get sent home with a cuff, right? Somebody asked the question earlier, is it the cuff or is it the data? I think it was Dr. Bird, you had asked. I think that's a tough question because the cuff can give you data, but then if you go to that provider and say, hey, I have this data, and the provider's like, well, here your blood pressure is 140 over 90, go home, and then you get readmitted with superimposed or, you know, postpartum preeclampsia with severe features a week later, and you're on MAG, that patient didn't feel heard. And so I think this has actually probably been my most humbling and shocking finding in talking to a lot of these patients. And I've heard this a few times. My child's pediatrician told me my blood pressure was too high, and I'm not even kidding. So humbling experience. I mean, I have cried with these people. I've laughed with these people. It is humbling. And then I do telehealth. And so you are seeing the raw facet of these women in their houses. You see the background of their houses. You see bottles. You see their bed. You see their breastfeeding. I tell them to please feed if they need to. So it's been just a really humbling experience, even though it's not been that long. I have to, again, this is not it is a one-man show in terms of the clinic, but obviously not a one-man show with all the people that are willing to help with this. I'm trying to build collaborations on the Grady side and the Emory side right now. Again, the regional goal would be to build it within Georgia to get more collaborations with primary care, mid-level providers, because this is not going to be remotely a one-man show if we need to try to make this better. And I truly think if we take this opportunity, you could actually move the needle a bit on maternal morbidity and mortality, because you would avoid it the next go around and hopefully give them some education. But these are just some of the invested groups that I've been working with. I am a researcher at the core, can't take that away from me. So of course I have to think about all the research potential out of this clinic, both mechanistically and from a clinical social determinants of health perspective. So we have written a couple of grants for it. Dr. Ellis and I keep trying and thinking because, you know, we just keep having ideas. And so we keep thinking of where we can apply, but these are some of our thoughts for the future. Anyone who's interested, please reach out. And then last but not least, when we were this clinic experience, plus being on the cardiac bundle with GaPQC, we talk a lot about education, and we've done a lot for provider education. We have those beautiful pamphlets, we've got the video series. I mean, we've got a lot going on. But for me, it became like, wow, I don't think the patients really understand what's going on. I think patient education is really important. And so again, got an idea and I was like, hey, Missy, I think a patient education video series would be cool. And she goes, well, you should do it. I'm like, wow, her theme is cool. I get it. If I tell her something, she's like, well, you should do it. I was like, okay, well, I should do it. Well, I know zero about AV tech. In fact, my fellows and my colleagues at work have told me I'm like kind of in, it's not nice to say, but they say I'm an old person because I can't use tech real well. I figured out my email signature recently. So I was like, all right, well, how do we do this? Like, I mean, I know how to record on like an iPhone, but how do you do this? Well, Missy is like, no, I have young people involved. So patients over there, you can stand up. She's like, no, I got this. She's like, I can do a video for you. And I'm like, that's great. And then I was like, now we need someone to talk. Who's going to talk? Because we decided we want to create simple videos. What is your heart? What is blood pressure? What is diabetes? What is blood sugar? And we wanted to have people from different facets of kind of the OB training, residents, fellows, attendings, people who look different, people of all kinds doing this. So we got big dreams. And we managed to get our first video made before this conference. I'm going to try to play it now. This might be the hardest part of today, because remember I said I'm not good at tech. But the video is made, so I don't know, do I just click next? This should work. And right, I'm like, really? Do I just click the button? And Natalie Polyektev, who's not here today because bless her heart, she's sleeping because she's working nights at Grady, is the third-year resident who's applying an MFM who did this video for us, and patients helped with the editing, and actually Natalie's husband helped with the recording. So it took a village to get this video done too. But, and then we all worked on the verbiage and wanted to make it kind of a fourth grade level. So this is kind of what we're trying to do. We've talked to Lisa, we've talked to the team. The idea is to have QR codes so that when the mom is trying to breastfeed at 2 a.m. and it's on her phone, she can just click and watch this video. That's our goal with it. There we go.
Hi, everyone. We are so excited to introduce our new GaPQC patient education videos. My name is Natalie Polyektev, and I am an OBGYN resident physician. Today, we are going to talk all about the heart. The heart is arguably one of the most important parts of our bodies. It keeps blood pumping and allows all of our organs to get oxygen so that we can stay alive. During pregnancy, the heart and blood vessels go through many changes to be able to help the pregnancy grow and supply oxygen to the baby as well. So today, we want to talk about what changes your heart goes through during pregnancy and after birth. What are some normal symptoms that you may experience because of these changes? And what are some symptoms that can be abnormal or worrisome and may require a visit to your doctor? The heart and blood vessels go through major changes early in pregnancy, even as early as the first 2 months. The first change is that your heart starts to beat faster and harder. The heart must work harder in order to pump blood through the body and to the growing baby. And later in pregnancy, the heart is pumping almost 1.5 times the amount of blood it was before pregnancy. At the time of delivery, the heart is pumping almost twice as hard as it was before pregnancy. And right after the birth of the baby, all of that extra blood that was being supplied to the uterus then goes back to the rest of the body. And the way that your body gets rid of all of that extra volume is that it has to pee it out. But this can take time. So for the first week or so postpartum, your body is going through a lot of fluid shifts. It can take up to a full year for your body to go back to the way it was before pregnancy, but most of the changes that occur during pregnancy resolve in about the first 6 weeks postpartum. We know that pregnancy can be exhausting and people can feel very tired, but feeling so fatigued that you cannot do basic daily activities is not normal. And because your heart is working harder, it can feel normal to be winded or to feel your heart racing when you exercise or when you go up multiple flights of stairs. However, having a hard time breathing when you aren't doing anything, or if it's waking you up at night when you're sleeping, that is not normal. And while it's common to have trouble sleeping due to the aches and discomforts of pregnancy, it's not normal to need more and more pillows in order to sleep more upright due to trouble breathing when you lie flat. While it can be normal to feel your heart racing or skipping occasional beats, these episodes should always go away on their own and only last a few seconds. If you're feeling your heart racing or skipping beats, and it's also making you feel lightheaded or like you're going to faint, it is important to call your doctor. Because of all of that extra blood that's circulating through your body during pregnancy, it's also common to have more swelling, especially in your feet at the end of a long day. It's usually of no concern to have a little bit of swelling in your feet and in your ankles, especially if both of your feet look the same and if the swelling goes down with rest. But if you notice that only one leg is swollen, or if it's red and painful, or if the swelling is sudden and severe, you should call your doctor. And since these heart changes can last for a full year after pregnancy, make sure to tell any doctor that you see that you've been pregnant in the last year. So just remember, our bodies are truly amazing and they go through major changes to support a pregnancy. Being aware of what signs might be normal and what might not be normal is important to know. So I hope that by talking about what the heart does during pregnancy, you'll be better able to take care of your heart and your body.